Are we there?
Yeah, see.
Hello, welcome to Fertility Fact or Fiction, our weekly show from Windsor, Ontario, Canada on all things related to fertility. And this week we have another episode, but we are not going to be showing you a study. We're actually just going to take your questions because there seems to be a lack of good studies to review these days. So we do have a special guest coming on next week. We're going to have Canada surrogacy community joining us, and we're going to be reviewing her new egg donor agency with Angela, one of our amazing partners and colleagues, and we're really excited to have her on board. But that'll happen next week. This week, we are going to go right into your questions and discuss everything. And I also wanted to let you guys know that if you look at our YouTube channel, make sure you like, comment, and subscribe. Check out our embryo math video there, which now has 44,000 views as of today. And very soon we will have the top 5 lies about the COVID vaccine and fertility. So that should be ready this week and up. And hopefully you guys will enjoy that video too. It's got all sorts of pictures and little animations and videos, so it should be pretty cool. So very excited to be with you again tonight. Some really great stuff coming up. If you're watching us on Instagram, make sure you hit that like button and also subscribe or follow. We want to make sure that we build the following so that we can help more people. So hopefully we're running on all formats.
Almost. Almost.
Apparently we are not running on all formats. Do you have the respool yellow duck?
Nope. I think it's just, just any minute now. Okay, yeah.
All right, perfect. So,
yeah.
So we're going to start taking questions. Tarek has them all ready to go, hopefully somewhere. And if you have questions of your own, you can just start asking now. We do answer all your questions live. I don't come prepared. I take them as I get them. So this is the first time I've been able to, or the first show that's been able to do that. Everybody else kind of takes the questions ahead of time and comes up with pre-prepared answers, but I like the challenge. So hit me with your best shot and I will do my best to answer, although we do get stumped every once in a while. And we haven't been stumped for a little while.
I think you have a million.
The best stump ever was the one that asked us if rough sex altered your fertility care, and the answer is there was no data, so I couldn't answer that question. But it was a very interesting search on PubMed, and thank God we did it on PubMed, because if I typed in rough sex into Google, I can only imagine what we would have had. So anyways, fire away. I'm ready to go.
So first question is, few sperm found in first test. His latest found 0. Do we have a good chance? TESE.
So a testicular sperm extraction procedure is a reasonable choice. Do you have a good chance? It depends on what the reason that the sperm count was so low is. If it's obstructive, you would have a great chance. But if it's testicular failure, you would not have a very good chance, unfortunately. So it can vary quite a bit. That's more of a urological question because it's urologists that do that testing. But the reality is it's entirely dependent on the mechanism of what is going on. So if there's a blockage in the vas deferens, you got a great chance, because all that means is that the sperm is not getting out. Same thing if you have a damaged or scarred epididymis. You just have to go into the testis and you can get the sperm. But in the absence of that, if it's not a blockage problem, but rather it's a testicular failure problem, if the testicle isn't producing the sperm, then you're free, and you pull out the packages of sperm, you'll get access, and there will be lots there because they're waiting to be shipped. But if the problem is that the machinery that produces the sperm in the factory isn't working, there's no sperm to ship no matter where you're getting it from. So in that case, it's much more difficult to get a positive result.
Question from last week on YouTube. I just want to bring that up.
Oh, okay, cool. A last weeker.
Yeah. So as a PhD scientist and a woman in her 30s going through REI workup, I love listening to your Q&As.
Oh, awesome.
Great question from last week today. And one about ovarian damage from surgery impacting OR prompted me to ask a question. Sure. I had an ovarian ectopic with an IUD in place when I was 35 in 2018, treated with methotrexate.
Yeah, Trexate. Yeah.
Now I'm 38 and recently diagnosed with secondary infertility.
Okay.
And wondering if the implantation on my ovary plus or minus needling multiple rounds of methotrexate has reduced ovarian function on that side. My D3 AFCs have been good, between 10 and 20 the past few months, but my ectopic DX overlay is always lower in follicle counts. Coincidence, she wonders. We know so little about extra tubal ectopics in the literature. Thanks for putting this content out, Dr. Victor.
Wow. So thank you for the amazing question and for the shout out. That's very kind of you. Okay, so methotrexate really is a very low kind of aggression chemotherapeutic agent. So even if you took more than one shot for the ovarian ectopic, it is unlikely that would have had any impact, especially if you have 10 to 20 eggs on your day 3 antral follicle count. It's likely had no impact on your egg quality or on your ability to have a good response. Why is it lower when you're having the ectopics? That I can't answer. That, in fact, doesn't make a whole lot of sense because they're not interrelated. But the reality is if your antral follicle count is good, your AMH level is good, you shouldn't have to worry about the quality of your eggs or the number of eggs that you're producing, because both should be in a good range for you. If you're having recurrent ectopics, it is worth considering doing IVF in order to avoid the problem with the ectopics. So that is a therapy. And certainly if you've had more than 2 ectopics, we would frequently recommend it because 1 ectopic is usually less than 5% chance. Second ectopic, so you've already had one, your risk for a second is a 15% chance. If you've had more than 2, you're now looking at a 30% chance or greater for having an ectopic every time. And yes, we're good at detecting them and making sure we take care of you, but I mean, that's risky from a health standpoint because if, God forbid, it ever gets missed, that's potentially a very risky situation with maternal life-threatening problems, including blood loss, hemorrhage, ruptured tube. Sometimes even if it's embedded in the wall of the uterus, you can rupture the uterus. So there are a lot of factors that go into it. And so we don't want you getting multiple ectopics because that can mean multiple surgeries, multiple chemotherapies, a lot of worry, frustration, and time wasted as well. So if you've had more than 2 ectopics, you should definitely be considering the benefits of IVF. Excuse me, that's not to say you have to do it, but it's at least something you need to consider.
Okay. So, hi, Dr. Victory. Thank you so much for this show. If you only have 1 or 2 day 5 blasts, would you still recommend doing PGT-A testing? Why would you not just transfer one or both rather than risk potentially damaging the embryo during the biopsy when you, when you only have 1 anyways? Also, there seems to be a risk of discarding potentially good embryos if you receive a mosaic result, specifically citing a study that was just published showing 53.5% of the originally identified mosaic or embryos. Even as a 38-year-old, I am struggling to decide if PGT-A is something we should do.
So that's a great question. There's probably 100 different answers to this. And my answer to this, I hope, is fairly logical, and it goes as follows. If you only have 1 or 2 embryos, then the question is, God forbid, if it does not work, you won't, and you don't do the testing, you're not going to know if it was because your embryos were poor quality, or they were genetically abnormal, or if there was something else wrong. So the problem then becomes, what would you do next? If you failed, would you go immediately to donor egg? Because if you would, then my answer is, why bother doing the PGT testing? It's a waste of money. It's a waste of time. Transfer your embryos. If it works, hallelujah. If it doesn't work, you've decided to go on to using donor embryo. But if you're going to circle back to doing yourself and continue doing it for yourself, then I would be saying to you, well, hang on a second. Wouldn't you want to know that the embryos were normal so that you know why it's not working, or if that your egg quality? is the reason that it's not working. So I do think it depends not so much on what you're doing right there in that cycle, but what you would do if it, God forbid, didn't work. Now, the other part of this that's important is, does it improve your chances or alter your chances? So certainly over the age of 38, we know that a minimum of 2/3 of your embryos will be genetically not normal. So if you've only produced 2, there's a very reasonable chance that neither of the embryos are normal. So yes, there's a benefit to knowing, because you don't want to be transferring genetically abnormal embryos in you. But at the same time, if it doesn't work, you can likely estimate that the main reason, probably about 80% chance, was the embryo itself. So like I said, I don't focus so much on that specific cycle and what information to get out of it. I focus more on where is the flow of the decision-making process going to lead you to. So you didn't do your PGT, so there's our first step of the flow chart. Your next step down, see, this is why I need that drawing thing, because I could do the flow chart. Yeah, so the next step down would be, okay, am I going to donor? Yes, I'm going to go to donor. Well, then you don't really need the PGT, because if you failed, you're going to move to donor. So who cares? But if your next step is, well, I would consider going back to myself, then you need to really focus in on, do you have the information to make that decision properly? And there may even be a third arm, which is, I'll never accept a donor, in which case you don't need the PGT because you're going to only do yours until it works. Again, I would argue that it would be useful information to you in deciding how many cycles of IVF to do, to have the information about the PGT. But you are right at the cutoff if you're 38. So we don't do it for women less than 38. We only do it for 38 and over. Great question, though, and thanks for watching again. I appreciate that.
Question regarding smoking. How specifically smoking reduces male fertility? Is it reversible, and is it necessary? Any advice for young smokers who are trying to conceive? And does smoking reduce testosterone levels in males?
Okay, so it does reduce testosterone levels in males. The reason smokers cough so much is because inside your lungs, on the cells that line your lungs, are these little tiny, very microscopic hairs, and they wave back and forth, and that's what clears secretions out of your lungs. Smoking stops those hairs from moving, which is why smokers cough all the time, because they have to force the secretions up to get rid of them. And that's why they often have those kind of burly, sort of gurgly coughs. So the hair the hair protein on those cells is exactly the same structure as the tail of a sperm. And so the tails on sperm don't move, which is why male factor is so compromised by smoking, because it stops the sperm from moving. And if they are moving, they move much slower. On top of that, it does an enormous amount of oxidative damage, which then increases your sperm DNA fragmentation. And we know that that is associated with a huge 1,200% increase in your risk of miscarriage. So it impacts your testosterone, which is going to make you make less sperm. It impacts the motility of your sperm. It probably increases the number of abnormal sperm. It alters your sperm DNA fragmentation. What does all that translate into? Up to an 80% decrease in success. That is why we refuse to treat smokers, because I'm not going to charge you to do something for you and then compromise it by allowing you to have an 80% reduction in your success. So we literally make all of our patients quit. And that is imperative. So as far as advice, don't do treatment until you've quit smoking. How do you quit smoking? Number one, stop buying cigarettes. No one that is buying cigarettes is quitting smoking. So you have to stop buying cigarettes. Number two, change all of your habits associated with the smoking. If you read your paper and you smoke, stop doing that. Do something different. Walk and read the paper, or go for a jog, or jump on your treadmill, or buy an elliptical, or whatever you need to do. If you're a coffee and a cigarette, make a smoothie, do something healthy. Get rid of the habits that are associated with your smoking. If your friends smoke, you either need to get them to quit with you, or you need different friends or different things to do when they're out having a smoke. And lastly, there are loads of things you can do to help you quit smoking. Psychological treatments, laser treatments, Champix, I think in the States it's called Chantix. There are all sorts of medications. There's all sorts of treatments, hypnotism, you name it, it's available. So do whatever you got to do to quit smoking, but please do not go into it. If you need more proof that it's damaging, babies that are made from parents that smoke, whether it's male or female, have higher risks of heart disease and cancer when they grow into adults. So you're actually literally setting your child up for heart disease and cancer. So you cannot smoke when you're trying to conceive. And let's all be honest about this. No one should be smoking. The package says this can kill you right on the side. If I lit, a pile of gasoline on fire and said step through it, nobody would do it. But for some reason, people take cigarettes all the time. It's no different. You're just killing yourself in a slower or faster way. So please, please, please quit smoking. It is terrible for your fertility. It is terrible for your health.
Thoughts, dermoid cysts and transfers, to remove or not to remove?
Oh,
Like that one.
So yeah, that's a good question. So the problem with the dermoid cyst is dermoids tend to get bigger. So that's going to lead to 3 separate problems. Number 1, it could cause pain or some discomfort during your pregnancy. Number 2, it can alter your ovarian reserve because as your cysts get bigger, they're pushing on the shell of the ovary where your eggs are, and you can actually compromise blood flow to the ovary, which then compromises your egg quality for your next baby. And number 3, if it gets big enough, especially with the uterus growing, your ovary can tort or twist. You now have a surgical emergency because you got to run in there and save the ovary, plus it hurts like hell, in which case you're now being operated on during the pregnancy. And if you're operated on while you're pregnant, that's definitely a problem because you can compromise the pregnancy potentially. Not to mention many times if you don't have an expert operating on you, they're going to want to cut you open instead of just doing it laparoscopically. So it's a bit of a nightmare. So if the dermoid's really small, 1 centimeter, 2 centimeters, you could, in theory, get away with it. But if it's anything bigger than that, I would recommend taking it out. And even if it's smaller, if you have an expert surgeon, and I always emphasize, if you have an expert surgeon, not all surgeons are the same. If they know how to carefully extract the dermoid from your ovary without doing damage to the ovary, then I would recommend removing it, especially if it's larger, because your torsion risk where the ovary twists is quite high. And you don't want to experience that. It's painful, it's terrible, it will necessitate emergent surgery. You never want emergent surgery when you're pregnant because that's the worst way to do it. You want to calm, prepared, your bowel cleaned out, like everything organized. You don't want to rush into things.
Yeah.
Great question. No one's asked us that before.
You got a bunch of them today.
Okay, good.
Hello. I was just told by my family doctor that my kidney function is slightly low, 50. Is this a concern before starting an IVF cycle?
Kidney function? So there's a lot of different ways to measure your kidney function. I'm not sure what they're referring to by saying 50, but the reality is that that's probably not a huge concern unless you actually have some degree of kidney failure. So I don't have quite enough information there, but I mean, certainly if they were worried that the function of your kidney is low, that's problematic. If your creatinine was low, which may be where the 50 is coming from, that's not low, that's normal, in which case you have nothing to worry about. So that would be perfectly fine. But if you actually have some degree of kidney failure, pregnancy will strain your kidneys because you're increasing your blood flow by 50%. So you're just churning your blood through your kidneys. And it can put an additional strain on them. So you definitely want to get that checked out. You may even need to see a nephrologist, a kidney specialist.
Does Lupron depot change ERA results?
No, not as long as you're following the right path of treatment leading up to it. But don't do ERA because ERA is useless. So no matter what any fertility center is telling you, the ERA has categorically been proven to be an absolute waste of time and money. The only time it's useful is if you cannot get the endometrium to thicken and you're trying to figure out if it's receptive. Even then, I'm not sure, but it's like a last-ditch effort. But if you're trying to figure out the timing of your transfer, it is 100% useless. It does not work. Multiple studies have done that. We've done 3 videos on it because I kind of hate the thing. And all 3, including their own randomized controlled trial, showed absolutely no benefit whatsoever to doing the ERA. So please, please, please save your money. Do not do the ERA test. It's useless. But Lupron would not impact it. We used to use Lupron when we were doing ours.
Can I get pregnant naturally if my tube's blocked?
No. Not if they're blocked. I mean, the sperm has to get through your cervix, up into your uterus, and into the tube to meet the egg. And the egg has to get through the tube. So if your tube is blocked, they can't get together. There's no way to make that work.
She sent the follow-up question. I lost my right tube after an ectopic, and my HSG said my left tube is blocked.
So HSG is controversial because a lot of HSGs are very painful. And if it was painful, your tube can spasm. And if the tube spasms, it may be kind of temporarily blocked, but not actually blocked. So I don't do a lot of HSGs, probably down to about once a month now, maybe less than that even. We do almost all of ours with the saline infusion sonohystogram. We've got a great video on YouTube on that. So check that out. Make sure you hit that like button and subscribe to our YouTube channel. But on there, check out the video for saline infusion sonohystogram. If you warm the fluid, if you warm the instruments, if you walk the patient through it, it's very non-invasive, so to speak. It's much more gentle, and we rarely have trouble telling if the tubes are open or not. So I would retry that before you jump into anything expensive like IVF.
What causes ovarian cysts to keep recurring, and how can I prevent them?
Well, if we can figure that out on tonight's show, we will all be billionaires and probably win several Nobel Prizes. So no one knows what causes ovarian cysts of any sort. But the way to prevent follicular cysts is to stay on birth control. Now, if you're trying to get pregnant, obviously that's not going to work. But if you're not trying to get pregnant and you keep rupturing cysts, then the best way to take care of that is to be on birth control, and that tends to work quite well.
What prenatals do you typically put your patients on? Low AMH, if that makes a difference.
So we use a number of them, and I'm not particular to any one brand. So we have a video on actually which prenatal is the best. So there's a company called NFH, and they make one called Prenatal SAP, which is quite good. We tend to use a lot of Pregvite Folic 5. YAD Technology has one called Fertile Pro Woman or Progestia. They're both quite good. And then there's the Materna Centrum Prenatal. Every company out there has one. In our video with Dr. Jennifer Strong, we actually compared them all. The NFH did have the best ratio of everything that was in there. And then Pregvite Folic 5 was number 2. So those are probably my top 2 choices, but just purely based on what's in them. But again, I don't support any one particular brand over another. So whatever works for you is fine, but those tend to be the strongest of the ones that are available. For low AMH, you want melatonin, you want lots of vitamin D, you want extra coenzyme Q10, you should probably be on iron. All of those things will help. Any kind of antioxidant vitamin will also be beneficial.
Summertime question.
Summertime question. All right, great. Fire away.
What temp can I lower my hot tub to during the first trimester? 90, 95, or lower, or don't even go?
Don't even go. So when you jump into a hot tub, your body is being exposed to a much higher temperature than normal. So what ends up happening is your blood vessels rush to the surface to try and cool your skin temperature. That then causes blood flow to be distracted from your uterus because you're pulling it to your skin surface, and that's never a good idea. So don't go in a hot tub when you're pregnant. Plus, you'll pass out if you get hot in a hot tub. So definitely don't do that. Stay out of the hot tub for sure.
Diet for fertility boost.
Mediterranean diet has been proven to be beneficial. Low sugar, low carbs. That's definitely very good. 6 meals a day if you're struggling with your weight and keep your calories under 1,500. Stay away from red meat, probably anything unnatural, synthetic, processed sugars, stuff like that. So as healthy, natural as you can. So lots of fresh vegetables, lots of grains. Seafood is probably okay if it's not in excess. You know, fresh fruits, squeezed juices, smoothies, yogurt, stuff like that. So the Mediterranean diet, and again, we've got a video on that too, has been shown to improve your IVF outcomes. So that's the best one to use if you're trying to conceive.
If an IUI fails, do you recommend trying again the next cycle or waiting between?
That's been looked at, and there's absolutely no difference. You can go back to back. There's no reason to wait. So if you're under 40, up to 6 tries is reasonable. If you're over 40, up to 3. But the timing of it doesn't matter. And certainly if you're older, the faster you get it done, the better, because if it's not working, you want to progress as quickly as possible because your ovarian reserve may become an issue. That was easy. Thank you for the easy question.
What testing would you request for 1 miscarriage at 7 weeks and 2 chemical pregnancies? 31 years old, AMH 7.7 picomoles per liter, 1 living child, 1 lost prior.
I would actually do a full recurrent pregnancy loss workup for you. So that's pretty extensive for us. Everybody's different. We would do your hormones, your thyroid antibodies, your vitamin levels, especially D. Check your iron level. We would do a saline infusion sonohystogram and 3D to check the shape of your uterus. We use fertility to check for intrauterine infections, STD screen, ureaplasma mycoplasma screen, thrombophilia screen, genetics testing, and I think that's everything. I might be missing one, but I think that's all of it. Sometimes immune system screening as well. I would love to do it for everybody, but it's super expensive. So we do all the other tests first. And then if you're still still negative for everything, we can explore the potential for the need for an immune test. So that's kind of all the female testing. For the guys, they need a sperm test, like a semen analysis, and a sperm DNA fragmentation test, and then a karyotype as well to check their genetics also. So that's like a very comprehensive approach to recurrent pregnancy loss. You do qualify if you've had 2 chemicals and 1 loss. So yeah, I think you merit getting the whole kit, especially if you're only 31. That's pretty unusual. Something must be going on. First step, make sure neither you nor your partner are smoking, drinking, or using marijuana, because remember, that is a huge increase in your risk of miscarriage. So there are some easy things we do as well, just to go through your history, make sure there are not factors in there. If weight is a factor, that can be a problem. If there's substance use, that can be a problem. Sometimes exposures through the workplace, all sorts of different things that we carefully address as we're going through it.
What is your view on Shuttle's method? Does it actually work?
No idea. What's Shuttle's method?
Shuttles? I don't know. That's what I got here.
Shuttle's method. Never heard of it before. Let's look up Shuttle's method. That sounds cool. Ask me the next one while I look up Shuttle's method. What is Shuttle's method?
Is there any studies that show gender at a certain time in the month if trying for either or?
The Shuttle's method is a child conception idea that is reputed to help determine a baby's sex. Okay, so this is a great one. There is absolutely not a single method you can use that will alter your chances of having a boy or a girl unless you're doing IVF, doing pre-implantation genetic testing, and then going ahead and doing selection of the embryos based on whether they're male or female. Every other claim that they can alter the success rate for having a boy versus a girl is absolute garbage. There is no way to do it. You're literally talking about millions of sperm getting inside your system. If there is some way to filter out boy from girl sperm, nobody on the planet knows how to do it. And I can assure you there is no natural way you can do it. There's no medication to take, no dating, no calendar that's going to alter the filtration of literally millions and millions of sperm. Out of millions and millions of people, even if I put 1 million people in my parking lot, and that's only 1 million, we're talking about 50 or 100 million. But even if I put 1 million out in the parking lot And I said run. Are you honestly going to tell me that there isn't going to be some females that are faster than some of the guys and some guys that are faster than some of the females? It's statistically impossible. So it just doesn't work like that, guys. Do not try and adjust the sex of your baby based on any type of method. The Chinese calendar, yogurt. My mom said that there was some crazy concoction using some dead fish from some ancient pond that they had in their family. These are like the Middle Eastern, tweaks. There's all sorts of stuff out there. I love you, Mom, by the way, that people talk about. None of it works. It's absolute garbage. None of that stuff works. It's impossible.
For FET cycle, how thick should the lining be before starting with progesterone?
7 to 8 millimeters is pretty acceptable. And definitely no more than like 1.1, 1.2 at the highest. It depends on each patient, but we definitely don't recommend doing it when the patient has a very thick lining. So my embryologist likes 8 millimeters, so we try and target 8 millimeters. Excuse me.
What could mild cramping 5 days past IUI mean? PMS or something else? Seems too soon for implantation. Actually,
5 days post IUI is your implantation. That's when the embryo is landing and actually sticking. So it could very well be that. Alternatives, you may have some bleeding into the cyst that's left behind from the egg release. Could be infection sometimes. So anything's possible.
Thoughts on embryo glue and assistant hatching for first FET, PGS tested 5-day embryo.
So if your embryo is PGS tested, it's already hatched, unless they went into the embryo to do it, which most people do not do. So it's most likely already hatched. Otherwise, we do hatch ours. As far as embryo glue, we reviewed that on the show too. There is some evidence that embryo glue may be helpful. It's pricey and the evidence is not like 100%, but it does look like it's beneficial. So we haven't really gotten into it in our program because we're doing great without it, but it's a usable tool and it may be beneficial, we tend to do HCG wash, roughly gives you the same increase in success, way, way, way cheaper. I think we charge $100 for our HCG wash. Embryo glue is like $500-600. So
I'm 43. I had 6 eggs, 2 blasts waiting on PGS testing. What are the odds they will be normal?
You should watch our embryo math video. Hit the like, comment, and subscribe button on YouTube. But our embryo math video actually says that. So at 43, about 75 to 80% of your embryos are genetically not normal. So the statistics don't quite work out the way you would think, but the rough estimate is if you have 4 blastocysts, maybe one of them will be normal. You need 4 or 5 to maybe find one normal one. It doesn't actually work like that because it's a per embryo, and then you got to calculate probabilities, and I show you how to do that in the embryo math video. I actually have to call 2 math experts to figure out the equation because it's super sophisticated, but long and the short of it is it's not like, hey, I've got 5 embryos, 1 will be normal. There is a probability that out of 5 embryos, 1 will be normal. And that probability is reasonable, but it's not a guarantee by any means. So 2 embryos has a reasonable chance, but not a great chance.
Does seasonal allergy medicine negatively influence the sperm? If yes, what to do about it in spring?
It shouldn't in any way alter the sperm. I've never seen anything that discusses that, so you should be okay. If anything, reducing inflammation is generally good for sperm, and if your immune system is active because of allergies, quieting that down is probably a beneficial thing for sperm. So it shouldn't have any impact.
What kind of questions should I be asking my doctor since I had a failed transfer?
Okay, so embryo transfers fail for one of 3 reasons: the passenger, the passage, or the destination. So the passenger is your embryo. So was it a good embryo? What was the quality of the embryo? What was the grading of the embryo? How well did it survive the thaw? Was it expanding or was it still compacted? In other words, had it kind of woken up after the thaw? Was it PGT tested or not? These things are the embryo passenger questions you need to know. The passage, did they see well? Was there blood in the catheter? Was there mucus? Did they clear all the mucus before they did your embryo transfer? Was the transfer easy? Was it difficult? Was it quick? Did they bump the top of your uterus and initiate cramping? Did it go in the right place? How far from the top of the uterus did they put it? My old embryologist refused to listen to me and always went to the top of the uterus, which is one of many reasons I left, and would keep putting it way too high. It just doesn't work when it's that high, so you have to back off. So we put ours about 3/4 of a centimeter away from the fundus, and we get very, very, very good results with that. In terms of the destination, that's you. So what's your immune system like? Are there infections? What are your hormones like? What was your lining like? What kind of progesterone levels did you have? Did your lining compress? Are your vitamin levels okay? What's your weight like? What are your eating habits like? What's your stress level like? There's like a million things that go into it. Your immune system function. So the U part is probably the most critical part after the embryo. The embryo is number one. It's the main source of failure almost every time. But when that isn't the case, then definitely the destination is a big part of the equation. And so we have to check a whole bunch of different things on you to see what's wrong and what caused it. So I know that's a lot of information. We have like a stamp that we use in the chart that I can send to patients so that they can see everything I just said and review it if they want. But definitely there are a lot of elements that go into it. But the simple way to think about it is passenger, passage, and destination. So the passenger is your embryo, the passage is the transfer, and the destination is you. So ask your RE about all of those things.
27 and 2 recurrent miscarriages, no live birth. Estradiol is 75 picomoles, thyroid is at 0.29, and vitamin D 67 nanomoles.
Okay.
Continue trying or wait for better numbers on test?
Definitely wait for better numbers on test. Your TSH is overactive. That causes miscarriages, and your vitamin D is low. So up your vitamin D, fix your thyroid, and do a bunch of other tests, because at 27, you should have a very high success rate unless there's something wrong. So go hit the pause button. Don't do any more transfers. Figure out what's wrong. Go through those things I just talked about. Passenger, passage, and destination, in particular, focusing on you and focusing on the embryo as well. Was your partner smoking? Was your partner using marijuana? Is there a lot of alcohol use? What was this sperm DNA fragmentation like? All of these things are important to determine why you're failing. There is no really good reason why at 27 you would fail 2 embryo transfers unless something is going on there. So go through everything with a fine-tooth comb. Do not do more transfers till you know exactly what's going on, for sure. And I'm sorry you're going through that. That's unfortunate.
Should you abstain in the first trimester?
Abstain from what? Alcohol, yes. Sex, no. Drugs, yes. Sex, no. Yeah, I mean, if you're asking about sex, no, absolutely not. I mean, as long as you're not going wild, I always tell my patients, park the 50 Shades of Grey case under the bed. But as long as you're not going crazy, you're probably fine. There's nothing wrong with having sex. Yeah. But anything else, you should abstain. Smoking, drinking, drug use, excess of anything, whether it's sugar or fat or temperature or exercise, you should take it easy for everything else. But if you're asking about sex, there's absolutely no reason to abstain. Let me follow that up, actually. So we did get one patient that didn't want to reveal themselves, but asked in private if the hormones can alter your sex drive. They definitely can alter your sex drive. The medications we use can alter your sex drive. The stress alters your sex drive. The honey, my temperature's right, come running can definitely alter a guy's sex drive and ability to perform as well. So there are a lot of things in the fertility world that alter the sex drive. I am working on a video for you. I have not had time to get it done yet, but I'm going to work on that next, talking about sex and fertility. So do whatever you need to do to keep the sex life fun, exciting, enjoyable. Don't get focused so much on, oh my God, I got to have sex right now, because you actually don't. Sperm can live in you for up to 3 days, and it can still get you pregnant. So you don't have to have sex right then and there. It's not going to drastically alter anything. So make it more of an enjoyable thing rather than I have to do it right now thing.
Hey, Dr. Victory, can baby aspirin cause subchronic hematosis?
Subchorionic hematomas. Yeah.
I just had 2 that cause a miscarriage. Is there a way to prevent subchronic hematomas in the future pregnancies?
So baby aspirin has not been proven to increase subchorionic hemorrhage, but it probably could. But the question is, does a subchorionic hemorrhage cause a miscarriage? And the answer is probably not. So most of the time when you get a subchorionic hemorrhage, it's not big enough to cause a miscarriage. So you'd have to have a huge SCH in order to do that. So typically, if you're having a miscarriage, it's not related to the SCH, it's related to the embryo, in that it's probably not genetically normal. So certainly if you've had 2 in a row, bleeding was the cause, I'd probably avoid the aspirin. I'd also probably go back and have a look at the shape of your uterus, whether you have fibroids, polyps, if there's infection in there, that kind of thing, because it may be some other cause of the subchorionic hemorrhage rather than just the aspirin. Yeah.
Do you recommend ICSI when there is no obvious male factor, but poor embryo results for 39-year-old female?
Yeah, so I always recommend ICSI, but that's because our embryologist has like an insanely high success rate with ICSI, and we don't want to watch embryos or eggs not turn into embryos or develop well. On the flip side, there isn't very good evidence to support that, but the studies that look at it do not have people getting the same success rates we do. So it's really hard to judge, because the studies all say if you don't have severe male factor, you don't need to do ICSI because it's not beneficial, but they're doing it in centers that have like a 50 to 70% ICSI success. We're over 95%. So it varies, and you can't really compare apples to apples there. It's more like apples to watermelons or something. So realistically, my advice would be do ICSI, especially at 39, because you're going to have less eggs and you want to make sure you fertilize every single one. I don't know necessarily it'll have any improvement in your embryo quality. In fact, it may not. So that may not be beneficial for you, but it will potentially improve your chances of at least getting an embryo. And then from there, it's a matter of how well the embryo develops. Great question. We've never had that one before either. Thanks for asking that.
What do you think of NIPT for microdeletions?
You can pick up some microdeletions with NIPT, but not all of them. So it depends on what you're looking for. And that's a question to ask a geneticist and the center that's going to run your NIPT test. But you can detect some, you just can't detect them all.
What is the recommended wait time for an FET after the second COVID vaccine shot?
You don't really need to wait. So there's actually, right now I'm working on a video for you guys on the 5 big lies with COVID and the COVID vaccine and fertility. So I will go through all of that with you. It should be available by the end of the week or the weekend for sure. But bottom line is the second dose really doesn't do a ton to your immune system. It's just a booster dose. So, I mean, I wouldn't do it the same day or maybe within a week, but after that, you're probably fine. It's not going to make a difference. It's the first dose that really sets your immune system on fire.
Hi, Dr. Victory. I'm a patient of yours who started the IVF a year ago, and I'm supposed to do a surgery for my extremely T-shaped uterus, but we do the transfer, but because of COVID, everything got postponed.
Right.
Do you have any updates when you're going to start non-emergency surgeries? And also because of my situation, what is your opinion on the COVID vaccine? Thanks. You are the best.
So thank you. So we don't have any word on emergency surgeries, but once the lockdown lifts, they'll gradually phase them back in. And I'm sorry, but obviously it's not in my control at all, or else I would help you in a heartbeat. As far as the COVID vaccine, 100 million%, go get the COVID vaccine. There is no biological way for the COVID vaccine to do any of the things that people claim it does. It cannot alter your menstruation. It cannot cause any problems with your baby. It cannot cause problems with your fertility. It cannot cause problems with sperm. It's all garbage. Like, it's just people making up stuff to try and scare other people away. There is not a speck of truth to any of it. So if you have the opportunity to get the COVID vaccine, don't walk, run and go and get the COVID vaccine as the very first thing you do. You are protecting your baby. Your risk of death from getting COVID while pregnant is 22.3 times higher. Your risk of miscarriage is something like 400 times or 400% higher. Your risk of preeclampsia is higher. Risk of stillbirth is higher. Every bad thing that can happen to you is higher if you get COVID in pregnancy, way beyond any even theoretical risk of COVID on fertility. Can it cause you to become infertile? Nope. Can it cause miscarriages? Proven categorically not to happen. None of this stuff is true. It's just people trying to scare you away from something valuable. So don't listen to the crazies. Run and get your COVID vaccine.
Would we be good candidates for IUI? MFI, only motility issues, latest SA, 50 million sperm and 21.6 motile.
Yeah. Anything over 14 million for your TMC is a good count. So if you're down to 21.6, if you're talking about a total motile count of 21.6 million, you'd be fine. If you mean only 21% are motile out of 50 million, that's probably borderline. So it would depend on how many mills you had and how many of them were normal and how fast they go and all of that stuff. So if you're talking about a total motile count, we've reviewed on the show before. It's on our YouTube channel and actually just got published this month. There are two different studies looking at the number of sperm you need to be successful in an IUI. One said 9 million, the other said 14 million, but you get the idea. Somewhere in that range is probably appropriate to give you a reasonable chance of success.
Does diet really make an impact? Always worried about what I'm eating.
Does it matter enough that you should always be worried about your eating? No. As two lovers of food can tell you, Tarek and myself, we had about a half-hour debate about what to eat tonight. Yeah, I don't think one meal is going to make a difference. But if you're persistently eating poorly, that's not going to be good. If you're persistently eating to the point where you're so strict, you're stressed about everything, that's also not going to be good. So look, if you want a piece of chocolate, have a piece of chocolate. If you're going to eat chocolate night and day and lunch and, you know, every other snack as well, that's definitely not a good idea. Thank God this camera doesn't pan to the wall of chocolate right next to us.
Nobody can see that.
I do like chocolate, but I'm not trying to have kids anymore. Yeah.
How many follicles on average could you yield at AMH of 1.05 nanograms at 42?
Well, I'm guessing, but probably somewhere between 4 to 8. If you were really lucky, 10 in that range. Yeah. 3 to 9 is what there's a very large Australian study that looked at, I think it was over 100,000 cycles, and they looked at the averages for women in the different age groups. You can see it on our embryo math video. So go to YouTube, DR Victory, and look for embryo math. Hit that subscribe button and check that out. So in that video, there's a graph, and that graph says that the average number, the peak, is between 3 to 9 for that age group.
I have a question here that you're going to love. We answered it last week. I'm
Okay.
pretty sure we answered it last week.
All right.
I think you're going to be surprised that
It's back?
Again, yeah.
All right, great.
Okay. Hi, my clinic does not do dual stim.
Okay.
What are your recommended? What are your recommendations? I'm at one of the best clinics in Chicago, Northwestern. But they said the clinic does not have the logistics outside of ERs.
Doesn't have the logistics outside of
ERs.
Oh. Okay, so that's nonsense. There's absolutely no reason why any clinic can't do it unless they're batching. Northwestern is home to probably the second smartest person I know in fertility, which is Eve Feinberg. So sit Eve down and say, Eve, I want duostim. There's zero reason why they can't arrange it for you unless they're batching. So if they batch where they only do cycles during like 2 weeks and then they're off for 2 weeks, yeah, you can't do it because it's impossible. But if they're running all the time, and Northwestern's a big program. I mean, last time I checked, they were doing like 1,500 cycles a year. So if they're that big, I can't imagine they're batching. That would be like hellish. So they should be able to do it for you. There's no reason why they can't. If that's not working, you know, Ruhi is there. She's in Chicago. She's with the Vios Fertility Center with Angie Beltsos. So check them out. Shout out to Ruhi. Yeah.
I'm 33 years old, FSH 5.9, AMH 7.11 nanograms per mil. I have a 3 centimeter cyst on my ovary related to endo. Would you recommend surgery and try naturally and then IVF, or directly IVF without having the surgery? Thanks.
Okay, so I'm different than most people. If you have a 3 centimeter endometrioma, it's going to get bigger. And especially if you do IVF, it's definitely going to get bigger. So while your ovary will become weaker by removing the cyst, that is true. Your ovary is getting weaker by leaving the cyst. So it's very much a damned if you do, damned if you don't situation. My argument for this is when you're dealing with an ovarian cyst, there are 2 ways to do it. You can either make a cut on the ovary and open it and then peel the cyst out, kind of like just making a linear cut on an orange, peeling it open and then scooping out the inside. Or what some people do is they take the whole top of the ovary off. So now you've lost half of the ovary. And then they peel out just the bottom of the cyst because it's way easier. Okay, that's idiotic. And that's, you know, not being done the proper way. The other problem is that people go in, and when you remove an endometrioma, I don't care who you are or how good you are, there's going to be bleeding. And when you see the bleeding, if you start burning the ovary, which everybody does, you're doing thermal damage. That thermal damage literally cooks the eggs. So you can't barbecue the inside of an ovary. You got to put special chemicals in there to stop the bleeding. So there's all sorts of different things you can use, and that's what we do. I never burn the inside of an ovary because I know it's going to be harmful. So you've got to do that linear incision. It's got to be anti-mesenteric, meaning on the opposite side of the blood supply. You have to peel the ovary open carefully, very, very carefully separating the 2 planes of the ovarian cortex from where the cyst is. Go in and peel out the cyst. Don't burn the base where it's bleeding. Make sure they properly tamp it down so that the bleeding stops, and then go ahead and you know, put it in something that covers it so it's not adhesed. So I believe in doing the surgery first. Now, I'm in the minority for several reasons. Number one, most fertility centers no longer have physicians that do surgery. So they have to farm you out to someone else, and they're worried that if they tell you to go operate, you're going to run and say, well, I don't want surgery. I'm going to the next fertility center because these guys are crazy. So they'll just push you into the IVF. Number two, they all believe that the data regarding the ovarian cysts being removed and decreasing your ovarian reserve overwhelms the you know, improvement by getting rid of the endo. The truth is, if you leave the cyst, you also have a decrease in your ovarian reserve. And there's lots of studies that have shown that. So taking it out, yes, you're going to see a decrease. Leaving it in, you're going to see a decrease. So in my mind, if I'm going to see a decrease either way, why not get rid of the thing that's causing the problem? The other problem is that if you go in to do a ovarian egg retrieval and you have a cyst of endometriosis, you can't puncture the cyst. If you puncture the cyst, you're getting a whole lot of crud that doesn't belong there around your eggs, which is terrible for egg quality. And you're actually a much higher risk of infection of the ovary. And that is really bad because that's dangerous. You could lose your ovary. So we never recommend, going through one of those cysts. So it can make it difficult. So it is case by case. If it's way out on the outside, it looks like you can get access to the ovary. It's not a big cyst. Sure, you could arguably do the IVF, get your eggs out first, then go and take the endometrium out now that you're aiming for your embryo transfer. But if it's in the way or it's going to interfere with your egg retrieval, you got to kind of think about that and consider removing the cyst first. Fantastic question.
How long to wait to use fertility meds, Clomid or injections after the COVID-19 vaccination?
Okay, so the technical answer is there is evidence that there is no impact of the vaccine on your fertility outcomes. Having said that, in my mind, your immune system is super active, and that's not a great time to get pregnant because we know that it, A, probably decreases your chances, and B, likely increases your chances of miscarriage when your immune system's super active. So I'm telling my patients to wait 2 months from the first shot. But there is a study that has been published that says that there's absolutely no difference, that the COVID vaccine itself is not having an impact specifically on assisted reproductive technology outcomes, so that you can go ahead right away.
New term I've never heard before.
Okay.
Ovarian drilling.
Yep.
Thoughts on ovarian drilling if medication from letrozole and injectables is not successful?
Okay, so if ovarian drilling is where we take electrocautery and we literally poke holes in the ovary and burn them with electricity. It's extremely damaging to your ovary. It can cause adhesions and scarring, and I never recommend it. In fact, I have never done it before because I avoid it like the plague. So number one, I would try higher doses of letrozole. You can go up to 10 milligrams. Number two, you could use letrozole with shots as long as you're super careful. And then number three, make sure you're on all the adjunct therapies, which can promote ovulation. So that would be metformin, number one, and then the supplements, coenzyme Q10, inositol, and NAC. On top of that, if you are suffering from PCO and you're struggling with your weight, you have to bring down the weight. Trying this without bringing down the weight just doesn't work because you're looking at an 80% decrease even if you do ovulate. And when you're talking about a 8% chance and you've reduced it by 80%, you're down to a 1.6% chance. It's ludicrous. So make sure that you are addressing the whole package. It's the meds, which is the letrozole and the metformin, the supplements, and the weight. All three of them must be addressed. You cannot do a piecemeal where you say, well, I'm going to take the meds, but I'm not going to do the supplements and I'm not going to address my weight issue.
How long after a C-section should you wait to do IVF again? No embryos left over.
That's a good question. So we want you to breastfeed for 6 months, assuming you're breastfeeding. If you're not, I'm going to gently chastise you for not breastfeeding. So make sure you're breastfeeding. And if you've breastfed for 6 months, after that, it really doesn't matter. So anytime after that would be fine. If you're not breastfeeding because whatever reason you couldn't, the IVF itself, probably 3 months later would be reasonable. The transfer, you should probably still be waiting at least a couple of months if you're going to have another C-section. If you want to try a vaginal delivery, you got to wait a minimum of 9 months from when you did your previous section before getting pregnant again, preferably 15 months to minimize the risks of rupture when you try to deliver vaginally as part of a trial of labor after cesarean, or what we now call a TOLAC, which used to be called a VBAC, vaginal birth after cesarean. Have you noticed it flew by tonight?
Not only that, there's like a cajillion of them.
No, I mean like the time. It's 9. It's crazy.
Just question.
It's like nonstop. That's pretty cool. You guys kept us busy. I didn't even notice the time. You want to do Tarek's favorite question and end a bit early? Or is there still like a gajillion questions?
You could do your rapid fire thing if you feel correct.
You want me to do rapid fire? I'll do rapid fire.
So this is you live here. So
yeah. Just show me where I'm at that I need to answer from.
Oh, yeah, right here. This is the top.
Okay, we can do Rahi's rapid fire, and then Tarek's going to ask a bunch of questions. Just want to say thank you for taking the time to share your knowledge with us. You're welcome. After 4 egg retrievals and 2 FETs. I finally got my big fat positive. Thank you for empowering us to advocate for ourselves. I'd like your, oh, it disappeared, dude. I'd like your, I can't read the rest of it. I don't know. Oh, opinion on changing from daily PIO to every third day. Don't do it. It's the same, but never mess with things once you're successful. So stick with what you're doing. What are your thoughts? My progesterone measured 71, 11 days, post 5-day transfer, and 60. That's fine. Stick with it. Don't change anything. You're good. 2 missed miscarriages with normal embryos. I'm 34 years old and all tests are looking normal. You need a recurrent pregnancy loss workup. So get all of those tests that I talked about earlier: fertility-related, endometrial testing, immune testing, sperm DNA fragmentation, thrombophilia screen, evaluation of the inside of your uterus. There's a whole bunch of testing you need. Thyroid testing. What should I test? Yeah, everything that I just mentioned and many more. This video will be up, and does it go up right after this? Is it up for 24 hours?
Up for 24 hours, yeah.
So you'll be able to find the video on Facebook.
Oh yeah, it's
and
on the live stream.
Not on Instagram though.
The live stream's on Instagram.
Yeah, but the live stream will be on our Facebook. So that's Victory Reproductive Care.
And YouTube.
And YouTube. So just go back and check it out for the first, what was that, about 10, 15 minutes into the show, right? And you'll see that we talked about it there. So check that out. Oh my God, there's people joining now. Kasha's joined. Hey, Kasha, love you. You're amazing. Have you heard about any benefit of red light therapy? People keep asking us about that. You know what? People keep asking about this red light therapy. I looked it up. There's absolutely not a shred of anything to talk about red light therapy. I did have laser on my shoulder today. Doesn't feel any different yet, but who knows? We'll see. During my first cycle, I produced 11 eggs, but due to the poor sperm quality, just got 4 embryos with good quality. But after the first 2 embryo transfer failed, with next 2, I now have a daughter. Oh, congratulations. To have another baby, I will have to do all over again. Do I will have the same or better chance? It depends on your age. It's likely a little bit better because you've been pregnant, and it may be a little bit worse because of age. So it's hard to know. What are the potential consequences of doing PGT-A? I had 3 day 5 blastocysts with 2 being PGA tested. I'm 31 years old. Oh, you asked this earlier. So the potential consequences are harm to the embryo, but it's very rare. There is one study that suggests that the chances are lower with PGA testing in young women like you. But that's the only study that's shown that. And I can guarantee you there's a lot of people that would argue that. So probably not a lot if it was done properly. Tatiana, hi, I just had my FET. We transferred 3 embryos. Whoa, we got pregnant, but I've been very tired and I've been having lower pain like contraction. Is that normal? Tired is normal. Lower pain like contractions is not. Please go make sure you don't have an ectopic or that you now have triplets. Why did they transfer 3 embryos, Tatiana? That's crazy. Should everyone take aspirin after a transfer? No, everyone should take aspirin before, during, and after the transfer. If you started after, you're kind of late, so you want to start it before. Most people does, but I was told by my IVF doctor to stop taking it since I was spotting. Oh, the aspirin? Oh, that's for the cramping. I think that's for the cramping. Yeah, if you're talking about aspirin, Tatiana, you're fine to take the aspirin, but the cramping you need to look at. And if you're spotting, you definitely stop the aspirin. Fit Farm D from Michigan. You're awesome, by the way. I love you. Maybe GFR. Yeah, maybe. That's the glomerular filtration rate for that lady that asked about the number 50. Can I get pregnant with triplets or twins if I transfer 3 great embryos? Yes. Not only can you, you likely did. What is more dangerous, living with a large covering almost the entirety of the ovary cyst, or removing the cyst and ovary? Remove the cyst. That's not dangerous. As long as you have a good surgeon, it's perfectly safe. Oh, I did that crazy thing with your keyboard. I don't know how that works. How do you get rid of your keyboard?
Push the down button.
Is that a button? Oh, that thing. Oh, cool. Okay. More rapid fire. Man, more people are joining. If all blood work comes back normal after 3 consecutive miscarriages, what is recommended? More testing, because they probably didn't do all the blood work you needed. And it's not always just blood tests. There's endometrial tests, there's sperm tests, there's all sorts of stuff. What is a good score on the DNA fragmentation test? Less than 15% is good to excellent. I had a tubal several years ago, but now we want another baby. Some doctors have suggested to not do a tubal reversal and just do IVF. Others say tubal reversal. It's entirely age dependent and sperm quality dependent. Get your hubby's sperm checked. Make sure you check yourself out first and then make a balanced decision. The reason people recommend IVF over tubal reversals is because they don't make as much money doing a tubal reversal. I don't care about money, so we do both all the time. And sometimes it's appropriate to do the tubal reversal, especially if you want more than one baby. Sometimes it's more appropriate to do the IVF. So if your husband's got terrible sperm, you're going to need the IVF anyways. So sometimes that's important. If he's got great sperm, why would you do IVF? It doesn't make sense. You know, I realized watching myself as I'm doing this that I keep talking with my hands. Can I get the COVID vaccine if I am pregnant? Yes, please run, get the COVID vaccine. Most of my coworkers got the vaccine in the pregnancy in the second trimester. Not needed, you can get it in the first. I just had my first transfer, so I'm less than 4 weeks pregnant. Go ahead and have your transfer. Chocolate. Someone wrote chocolate. If ACOG has specific recommendations on when to get the vaccine, definitely worth exploring. ACOG does have specific recommendations. They all say just get the vaccine. I kind of believe your transfers should be delayed a bit, just because I do think it'll have an impact, but who knows. Is it the same age as PCOS? Is it the same as PCOS? I'm not sure what you're asking about, if what is the same as PCOS. Is your opinion, how long should you breastfeed? Minimum 6 months, preferably a year. How long is ovarian cyst removal recovery? And how soon after do you suggest waiting to try to get pregnant? You can get pregnant right away. Recovery, if they open you, 6 weeks. If they do it laparoscopic, 4 or 5 days. 2 consecutive chemicals, one with PGS tested, one not. After a live birth from a previous PGS tested embryo, what should I do before my next FET from a PGA tested embryo to optimize pregnancy? Oh, that's a huge question. That's the last one. I burned through it. Okay. Vitamin levels, exercise, Mediterranean diet, low stress levels, acupuncture. Try using our protocol for our frozen embryo transfer cycles. Be very positive, pray, meditate, yoga. Exercise every day, avoid everything bad, no smoking, no drinking, no drug use. Make sure your partner does the same. Have lots of sex. Sperm actually improves your chances of getting pregnant with an embryo transfer. So you want to make sure that there's actual ejaculate inside you in order to facilitate that process. So not just sex, but actually ejaculation in the vagina. I think we're done. Anything else? There's like a million more. Is there okay, we did Rahi's Rapid. Do we want Tariq's, what do we call it? Tariq's, good name for it, Tariq's terrific question.
Tariq's terrific question.
Yeah.
There's a lot of pressure on that, to be honest. I don't think that should be given every week, but we'll do it this week. And then we'll see.
And then we'll see. One question, or a whammy.
Okay. I don't know about when, but it seems to be a constant question.
All right.
Have you heard of an antihistamine protocol for pregnancy success and reduction of miscarriage?
Yes, and there's no good evidence that it works. I have tried it. I've seen it work sometimes. Other times it didn't do anything. I'm not a believer because I just don't think it makes enough of a difference. But there are some people that swear by it, and then there's studies that say it's ridiculous and it doesn't make a difference. So I think there are stronger ways to take care of your immune reactivity than antihistamines.
Oh, I got a good one.
Okay. Oh, now we got Tariq's too.
It's relevant to a lot of people, I'm sure.
All right.
So I'm a patient of yours.
Okay.
I just found out I'm pregnant last week.
Awesome. Congratulations.
But I got COVID-19. What should I do and what are your recommendations? I'm so worried.
She's got COVID-19 now. If you have COVID-19 now, just take care of yourself, take lots of vitamins. There's nothing you can do about the pregnancy to protect it. There's certainly nothing we know of. It can increase the risk of miscarriage if you get COVID, not the vaccine, but the actual COVID virus. But there's literally nothing you can do. So just be super healthy. Get your rest, get your fluids, take lots of vitamins, make sure your oxygen levels are appropriate, take very good care of yourself. For the love of God, stay away from everybody. That's all you can really do. Yeah.
We'll end it on that.
I think we should. Amazing show. Thanks for keeping us occupied for an hour and 11 minutes. Super excited to share all this stuff with you guys. Great show. Remember, go to our YouTube channel and hit that subscribe button. We are now at 2,460, I think, followers there. So it grows every day, whereas the damn Instagram doesn't grow no matter what we do. So follow us on YouTube, follow us on Instagram, tell your friends, give us 5 likes, share with some friends. We would love to have that happen. And we'll see you again next week and have another exciting show. Next week, we have Angela with us. So if you want to know about surrogacy or egg donation, she'll be here and we'll be running you through all these steps. Have a great day and we'll see you again soon. Take care, guys.